video will provide you an overview of the diagnostic categories in DSM-5. Pay attention, because this might help you with a future exercise. First up, we have neurodevelopmental disorders. This category includes diagnoses such as autism spectrum disorder, ADHD, and intellectual disability. What these disorders all have in common is that they tend to be diagnosed during childhood and tend to involve lasting alterations to one's neurodevelopment. The subsequent category is schizophrenia spectrum and other psychotic disorders. Psychosis refers to delusions, hallucinations, or significant alterations in cognitive processes. So that's what the disorders in this category have in common. Schizophrenia being the prototypical mental illness. Bipolar and related disorders include, obviously, bipolar disorder, which comes in two forms, 1 and 2, but also some related disorders such as cyclothymic disorder. Depressive disorders are pretty much what they sound like, though you can also find things here such as disruptive mood dysregulation disorder, sometimes criticized for being temper tantrum disorder. Anxiety disorders, obsessive compulsive and related disorders, and trauma and stressor related disorders used to all be in one category in DSM-4, but in DSM-5 were split out into 3 distinct categories. Anxiety disorders include things like specific phobias, social anxiety disorder, and generalized anxiety disorder. Of course, obsessive compulsive and related disorders includes OCD, but it also includes disorders that have similar features such as trichotillomania or excoriation disorder. Trauma and stressor-related disorders, as you might imagine, includes PTSD, post-traumatic stress disorder, but also encompasses the milder category of adjustment disorders, typically reserved for difficulties that have a duration of symptoms of less than 6 months and are not significantly disturbing enough to qualify for any other diagnosis in the DSM. Dissociative disorders involve alterations in one's sense of reality or connection to one's body. They're very commonly associated with traumatic stress and therefore are placed next to trauma and stress-related disorders in the DSM. Dissociation can best be described by a sense of spacing out or a sense of watching one's body from the outside. Somatic symptom disorders involve experiences of somatic symptoms, bodily-based symptoms, that have no known medical explanation. Feeding and eating disorders include what you would think in terms of anorexia, bulimia, and the newer binge eating disorder, but they also include disorders that used to be diagnosed in childhood, such as avoidant restrictive food intake disorder, or pica. Elimination disorders also includes disorders that used to usually be first diagnosed in childhood, such as enuresis and encopresis. These disorders involve difficulties with the expression of human waste, generally in inappropriate circumstances. Sleep-wake disorders involve difficulties with the sleeping and wake cycles, including the ever-prevalent insomnia. Sexual dysfunctions include problems with sexual performance that are distressing to the individual. In contrast with what's listed later, paraphilic disorders, those include difficulties with unusual attractions that are distressing to the individual, such as transvestic fetishism, for example. Note that a paraphilia is not in and of itself a disorder. It is only a disorder if it is distressing to the individual or involves criminal action in the violation of others' rights. Gender dysphoria is a controversial category, which we'll discuss more when it's time to cover that material. For now, know that this category is used as a diagnosis for individuals who do not feel their subjective sense of gender matches the physical characteristics of the sex they were born with. Disruptive impulse control and conduct disorders include diagnoses such as oppositional defiant disorder and intermittent explosive disorder. Substance use and addictive disorders include what you would think, difficulties with substance use, like alcohol, cocaine, opiates, but it also has a new diagnosis in DSM-5, gambling disorder. That doesn't have any substances involved except the ones that are naturally generated by your brain. Internet gaming disorder is under consideration for a future addition to this category as well. Neurocognitive disorders may sound an awful lot like neurodevelopmental disorders, but they do not have an onset during childhood. They typically have an onset in later adulthood, though they can have an onset at any time. For example, when someone experiences a traumatic brain injury that alters their cognitive functioning significantly, that would fall under neurocognitive disorders. Personality disorders are a bit difficult to describe and a relatively controversial category, especially because no one could agree on them in DSM-5, so they got left exactly as they were in DSM-4, even though we knew there were lots of problems with them in DSM-4. So we'll unpack that when we get to that section of the manual, but for now, know that it involves long-term difficulties in social occupational relational functioning, beginning by early adulthood. And we've already discussed paraphilic disorders. Other diagnoses that may be of clinical interest include what are known as the Z codes. Z is in zebra. And this is especially of interest to social workers because it includes environmental factors such as inadequate access to housing or significant relational problems. We know as social workers that the environment has a significant impact on someone's mental health, and so it's helpful to be familiar with the diagnoses in this category. Even though they are not billable to insurance, it's still part of a comprehensive assessment process to include relevant Z codes in our diagnosis and assessment of a client. Hopefully this brief overview is helping you get to know the DSM a bit better.